Today we're going to discuss the potential to empower our advanced practice nurses and will they save Texas lives if we do so. That's basically the message. Our four panelists, well, let's see, let's do the order that they're sitting in. I have my friend Ann Dunkelberg, who is the Associate Director for the Center for Public Policy Priorities. She focuses on issues related to healthcare and healthcare access. Before CPPP joined the center in 1994, she worked in the State Medicaid Director's Office at HHSC, where she was the primary author of the Texas, I didn't know this until I read your bio, the Texas Medicaid in Perspective, which many people don't know the title, but know the book as the Pink Book. It's kind of the Bible for Medicaid and Medicaid regulations. Anne has been recognized by Families USA in Washington as an outstanding consumer health advocate and by the LBJ School of Public Affairs Alumni Association as a distinguished public servant. She is a native Texan, received her BA at UT Austin and her MPA at LBJ School of Public Affairs, also at UT Austin. Next, we have, no, that's not Ray Callis, even though he
I almost got the flat top haircut today to see if I could fool you.
Dr. Ray Callis, good friend, colleague, anesthesiologist, is stuck in Beaumont, unable to get off the ground in the airplane. So Mr. Dan Finch is here substituting for Dr. Callis. Mr. Finch is I don't know what your actual title is, but he's Legislative Director of Affairs for Texas Medical Association. Is that right?
Close enough.
Then, of course, we have Representative Stephanie Click, who graduated from Texas Christian University with a Bachelor of Science in Nursing and has more than 3 decades of nursing experience. She currently is a nursing consultant and, of course, represents House District 91, which includes North Richland Hills, Haltom City, Watauga, and portions of Fort Worth. Stephanie has 4 grown children and has been married to her husband Don for more than 40 years. You still can't catch up with me. We got 51. Representative Click currently serves on the House Human Services and Public Affairs Committees. Last session, she was the co-author of House Bill 1415, which intended to release our advanced practice nurses, and we should also congratulate her on winning re-election with 60-some% of the vote?
64.
64, and can't beat that. And then, of course, we have Holly Jeffries, what I would call our real-world person in contrast to our policy people, the rest of us. Holly Jeffries is an advanced practice registered nurse, received her RN degree in 1997, completed her doctorate in nursing, gotta fix my bridge, in 2002 at University of Texas. She is a certified family nurse practitioner and leads a multidisciplinary healthcare team providing primary care services to underserved rural areas across the entire Texas Panhandle. Holly also serves on the Healthcare Advisory Board for the Lieutenant Governor and chairs the Government Action Committee for Texas Nurse Practitioners. So she is still involved in the political stuff, but really likes taking care of patients like the rest of us. Okay, now, those are our panel. Let me tell you what we're going to do. What I want to do is spend 2 minutes, hopefully not more, showing you the data that we do have a primary care shortage here in Texas, not the why, but simply the what. And then I'm going to ask our panelists what they propose to do about that problem. So just hit this. I did that. Okay, now Texas, population, 28,797,000, essentially 29 million. There are 62,816 doctors who have licenses to practice medicine in Texas and practice in Texas. There are actually another 18,000 who practice outside of Texas. Of them, 21,142 are primary care physicians. So you got 28 million people and 21,000 primary care physicians. There are 17,000 APRNs who provide primary care in the state of Texas. Now, the shortage that we have is both absolute and relative. By that I mean absolute, if you just do the math, we have one primary care physician for every 1,362 Texans, which is not exactly a ratio that you'd like. And number two, they tend to be concentrated in densely populated areas, and quite frankly, where the money is. And so places like the Panhandle and Hidalgo County simply don't have access to primary care. 35 of Texas' 254 counties have no doctor at all. And I'll show you one other, and then we can get to the panelists, which is, this is a distribution slide that we made here. Basically, what it shows is all that salmon stuff you see around the state of Texas is less than 100 primary care providers per 100,000 population. In other words, 1 to 1,000, less than, or using correct math, we have more than 1,000 people for every one provider in all the salmon areas. And the only areas where it's greater than 1 to 100 is those little brown areas. So I don't think I need to say any more to convince you that we have a real primary care shortage. And Lord knows those of you who try and access care, maybe not so much in Austin, but anywhere else, and Holly can speak to that, it's a real problem for patients. So without further ado, let's start with what is the regulatory situation, the regulatory environment in which APRNs find themselves in the state of Texas. In 2013, the Texas legislature passed Senate Bill 406, which basically created a thing called the Prescriptive Authority Agreement. The Prescriptive Authority Agreement has 4 things you should know about. Number 1, an advanced practice nurse can only write a prescription for any medication if she has one of these contracts with a delegating physician. The physician delegates his or her authority to write a script to the APRN. There is an exchange of money involved in these contracts. The average cost around the state to the APRN is around $20,000 a year. Number 3, the delegating physician periodically reviews the APRN medical records, the APRN practice. There are some specifics as to how often and so forth in the law, in the regulations. But there is an oversight or review process involved. And number 4, delegating physicians can have up to a maximum of 7 to as many as 10 of these prescriptive authority agreements. The greater number is in medically underserved areas. And without any further, I'd like to ask Holly what she thinks of this, and then we would go around, please.
Well, so what you suggested, the Senate bill that you talked about, did some good for us, because there was a mileage restriction before that. So with regards to rural areas, it lifted that, but we currently are still in the same place where it causes barriers to practice for us. And we know in other places that don't have those same barriers with the regulatory burdens, there's 3 things that happen. Access to care is increased, which is still a huge issue in Texas. I believe last year 400,000 people moved in. We had a natural growth of 200,000 people. We still have the shortage that you just showed us of providers, and that's even more grave in rural areas where I am. And so it increases access to care. If we were able to loosen those regulatory barriers. It also is cost effectiveness because they can get access to care in a timely manner. They don't have to end up in an ER somewhere. And then thirdly, it just, the quality of care is very good. And study after study shows that care given by APRNs is of high quality. It's safe, it's effective, cost effective, and high satisfaction rates from patients.
Thank you. Representative Click, I know that you proposed a solution to this, or a change. Would you care to describe what you thought was a good idea?
The legislation that I filed last session would have consolidated regulations under one board. Currently, that practice is regulated by both the medical board and the nursing board. There are not very many professions that are regulated by two different licensing boards, number one. Number two, the delegation agreements, it would have eliminated that. That is a barrier financially to opening practices. It also, the regulations that we have, puts us as a state at a competitive disadvantage. The New Mexico legislature has appropriated money to recruit Texas nurse practitioners because they have a more favorable practice environment than we do.
I will tell you that I actually heard former Governor Susana Martinez thank the state of Texas for all the excellently well-trained APRNs that New Mexico is recruiting. Mr. Finch, any thoughts from the TMA regarding the legislative, if you will, regulatory environment?
Let me, I can give you a very quick rundown of the, first of all, the TMA's core principle in this agreement is that independent diagnosing and prescribing is the practice of medicine. Physicians can delegate but must supervise because ultimately they're accountable. What we did in 2013 basically took a regulatory history since 1987 and all of its quirks and bookkeeping requirements that were a problem for nurse practitioners and physician assistants and physicians, and we sat down the Texas Medical Association, the Texas Academy of Family Physicians, the groups representing advanced practice registered nurses and physicians assistants, and said, here's our core principle, but everything else is open. What can we do that builds a team, the model team, care team for the future? And we scrapped the entire regulatory system that had grown up around the Rural Health Rescue Act of 1987, and this rather checklist of things that doctors and nurse practitioners and PAs had to do, which was basically you can't be more than 75 miles away because apparently one or the other got stupid at mile marker 76. Doctors had to be on site 20% of the time. Doctors had to look at 20% of the charts. From the medical board's regulatory standpoint, it was a great system because it was a checklist, but it didn't do anything to promote communication, collaboration, and better patient care. So we sat down as you think it's not possible, but we can sit down and do these. And we said, what should we fix? And we looked at all these accounting requirements as proxies for quality assurance. And we said, why don't we replace all these proxies with real quality assurance? And you can go to the legislation today and see that generally physicians and nurse practitioners and their PAs must meet on a relatively monthly basis. And the sole focus that the legislation said was to improve patient care services. And so prior to that time, doctors were charged with reviewing, 20% of the charts, then 10%. And doctors would call me and say, well, how many charts am I supposed to review? And I said, well, doctor, there's no legislative requirement that you review charts, but you know that chart review is a good part of quality assurance. And if the focus is on improving communication, collaboration, and care, why don't you do this? Why don't you have your nurse practitioner pull the most interesting, unusual, or difficult case that they had in the last 30 days and talk about it? Talk about what can we do better, How do we better communicate? How do we better care? How do we better collaborate in the care of these patients? And that was the focus. It was to build the team-based practice. I will tell you that as my children are much older now, but when my kids were real little, the pediatrics practice in Houston that we took them to was 4 pediatricians, 4 registered nurses, and a part-time receptionist bookkeeper. That was the infrastructure. You smile because you know that's much different today. That same practice today is 15 pediatricians. It's probably 10 nurse practitioners, a couple of PAs, a whole cadre of registered nurses, and an entire billing department to handle the paperwork. And I remember when they first added the first nurse practitioners to their practice in I want to say 87 or 88. And I and my wife and my friends were elated because that means we could get our kids in earlier. But the team of today, the old team was a solo practicing primary care doctor with a nurse and a receptionist taking care of a panel of 1,500 to 1,800 patients. That gives way to a primary care doctor, a nurse practitioner, a physician assistant, a variety of registered nurses, the entire billing department taking care of not 1,800 patients, but 4,000 or 5,000 patients, and it's not one doctor, it's 5 doctors, it's 10. That's how healthcare has changed, but that is the model that is for primary care these days. You're right, we absolutely are behind in terms of the absolute numbers of primary care providers in the state, and we have a fast-growing population. But we license over 5,000 physicians a year, and that is more than twice what we did in 2002. Having said that, though, a fast-growing population, we're having trouble getting ahead of it. It is a continuing challenge. We're getting ready to add. We just added a couple of new medical schools a few years ago. We're getting ready to add 3 more now to train the workforce of the future. And today's workforce, today's medical school experience is doctors and nurses and nurse practitioners and physician assistants training together. And they learn in medical school how to work as a team. And that, we believe, is how we're going to go. Now, if you'll give me just a second, in 1987, we passed the first legislation. It was called the Rural Healthcare Rescue Act of 1987. And for the very first time, it allowed physicians to delegate and supervise prescribing privileges by nurse practitioners and PAs at a remote location. In other words, not physically located in their own office. The idea and the concept was to grow small rural clinics and have the doctors basically ride the circuit. It was modestly, and maybe not even modestly, successful. But it did provide an avenue for recruiting and retaining nurse practitioners and involving them in this area. And I will tell you that 2 things happened. Number one, my office was in the Texas Medical Center. And in 1988, as a result of that legislation, that there was an incredible hiring frenzy in the Texas Medical Center in Houston for advanced practice nurses and PAs. By the definition of the Rural Healthcare Rescue Act, the most medically underserved area of our state had to be the Texas Medical Center in Houston. Well, that's not true, but that's where the jobs were. And so the economics dictate in many respects where practitioners go. I think doctors thought riding the circuit might be good, but apparently actually being in the car and going from place to place is not a really good use of their time. Rural healthcare has many, many challenges, and I think chief among them these days are the financial underpinnings for rural hospitals and rural healthcare facilities, because that's the heart of the infrastructure in rural Texas. And most of these little community hospitals were built in the 1950s and 1960s with federal dollars, and these facilities are aging out. And so what happens when the facility closes or cannot be renovated? It means that the infrastructure kind of goes away. The doctors and the nurses move out, and I think telemedicine, financially underpinning rural hospitals will be important moving forward, and 2, I think telemedicine gives us a real opportunity to extend these kinds of services for both primary care and specialty consultations to rural areas using the technology.
And do you have thoughts on the whole regulatory environment?
Well, to stay at a high level and not jump into the questions to come, I think my work is on advocacy for access to care, particularly for low-income Texans, concerns about Medicaid, concerns about CHIP, concerns about the uninsured, and about low-income people who are insured.
But still can't get access.
But still have access issues, so there's some different issues for those different groups. But even for example, in our marketplace for individual insurance now, we have people even below the poverty line or just above it getting private insurance, and it's really important to them to be able to buy a health insurance product that has really low out-of-pocket costs. And that means, we need to optimize, competitiveness and productivity in the healthcare marketplace. So I feel like, I've been watching this debate for over 20 years now, and I think that, Texas is obviously towards the end of the train of states in terms of expanding access to practice by these kinds of professionals. So in my opinion, this is one of the factors that is limiting access to care, particularly for low and moderate income Texans, who really need to have that more affordable access available, and many of whom live in underserved communities, whether that is rural or inner city.
So let me continue with you for a second and talk about Mr. Finch raised a very important issue, which is the safety and effectiveness of an APRN practicing whatever she was or he was trained to do. And so the question I would ask is, what does the evidence show in terms of the safety and effectiveness of APRNs in independent practice?
There is a kind of a staggeringly large body of research on this topic. One of the things that in the conversation around this issue, folks at this table have shared are resources, and it's really interesting because you have reports from think tanks that are normally identified as being very conservative, and then you have some that are affiliated with Brookings Institution, that include a bunch of economists who are more associated with more progressive institutions, and you find them agreeing on this, that
Right.
the preponderance of the evidence is that advanced practice nurses are effective, that outcomes are identical, and even some outcomes are better in most cases. And I guess the thing that I feel like, it's not that I am not interested and compelled by the concerns that the Medical Association has raised about safety or efficacy. It's just that I don't see the research basis for them. I don't feel like that's been brought forward, and we have everyone from Brookings to the American Enterprise Institute to the Institute of Medicine all saying that it's very beneficial to productivity, to competitiveness, and to access and
The
outcomes.
health of Texans. Holly, you want to chime in here? You're on the front.
Absolutely. So our clinics that we have, we're in 4 of those counties that don't have a physician. So we are rural. We don't have hospitals, no physicians. So one of the things that happened in the Texas Panhandle, which is really interesting, is, and this is fresh off the press from the VA, the Veterans Administration there in Amarillo, a year ago they gave all of their APRNs full practice authority.
Where was this?
At the Amarillo VA.
Okay.
The Veterans Administration. So for a year now, they've done full practice authority for all their APRNs in the Amarillo Veterans Hospital. So statistically, what they've come up with over the last year, in March of 2017, if you were a new patient and you wanted an appointment for primary care, you would call, and it would be a 16-day wait period. That was their average for 16 days. Today, after implementing APRNs full practice authority, they are at 3.39, which is so incredible. And then when we talk mental health statistics, it is amazing. They had 43 new patients in 2017 who were new veterans receiving new onset of mental health. And as of 10/31/18, they have doubled that to 98. And they've increased their mental health patient visits by 500 just by nothing else other than allowing nurse practitioners to practice to the full scope of their authority that they were already trained to do. No new interventions, just doing what they're allowed to do.
Representative Click, any thoughts?
Holly makes a great point. I mean, we've talked about access to primary care being an issue, but we also have a mental health provider crisis going on right now. And specialty trained APRNs are well suited to take care of those patients. And many of them right now, if a patient needs to see a psychiatrist, half of them are cash only. They don't do any insurance at all. And that's compounding the problem that we have. We have huge issues with mental health right now and not enough providers to address the needs of those patients. Nurse practitioners stand in the gap for that population as well.
We are well under the national average for both general psychiatry and child and adolescent psychiatry. And the problem is only more magnified by the current lack of big resources for substance use disorder and medically assisted treatment. And as we move forward in dealing with this opioid crisis, and I'm hopeful that we can begin. We've started addressing that in the legislature over the last couple of sessions in terms of rebuilding this frayed mental health infrastructure, and I'm hoping that that we will continue to do so to help build an infrastructure for the care of substance use disorder and for folks visiting or having drug use issues. If I could go back, Dr. Dean, and address the numbers of providers, because there are about 22,000 primary care physicians in the state of Texas. Family doctors, general internists, pediatricians, and OB-GYNs. And I think that there are a total of 17,000 advanced practice nurses in the state. But as we look at those numbers, you can take, and this is broad stroke, but 5,000 of them would be certified registered nurse anesthetists. So we'll pull those out of the mix. Now we're down to 12,000. And I know that half of the APRNs are choosing to work in specialty areas with surgeons for, after post-surgical care. So now we're down to 6,000 in primary care, which is a shortage. We still need more nurse practitioners. Then there are physician assistants who are similarly utilized. There's about 6,000 of them, but half of them are in specialty care. So now we're down to a universe of maybe 9,000 APRNs and PAs in primary care. All those folks are already working 40 hours plus per week in direct patient care services. And so if you change the schema to allow them to independently prescribe, because they will move to those 35 counties that don't have physicians, I don't reasonably see that happening. We're not actually changing the workforce, we're just shifting the equation from one side to the other. And I think that we see.
I can ask you, can you take that off? I'll give you this wireless microphone.
Oh, is this not working?
Cutting it out.
Yeah, unfortunately.
That's actually my voice. No, I'm just.
I promise we're not censoring.
All right, can you all hear me? Apparently I am not good with technology. Is this thing on or off? How's that?
Yeah.
Good.
So I'll go back and repeat everything I said since we started. No, these are issues that, this is the balloon that you squeeze and you don't know where it's going to pop out. But we are committed to working on them for the betterment of we will not always agree on stuff, but we are always open to the conversation to have. I talked earlier, and I see my friends with the APRNs and the Texas Nursing Association, and we'll meet to continue these discussions over the weekend and next week. The point is that we are trying to find ways that we can all move forward together. We're not just here to say no. Everybody says that's what we're here for. We have a core principle. But beyond that, let's move forward together and do what's right for Texas patients. I also have a question for, and Holly, maybe you can answer this, because you're actually in the
Trenches.
and in the field. What does it do to your liability and the risk that you take if you suddenly aren't working with physicians in a delegated manner? Does that increase your risk? Does it increase your exposure to lawsuits? Because doctors still get sued in this state, and they get sued for failure to diagnose more often than not.
Sure. No, that's a great question. Actually, the NSO, which is the national organization that does a lot of malpractice for nurse practitioners and advanced practice nurses, in their premiums that they set for advanced practice nurses, whether they're practicing in a state that's restricted or whether they're practicing in a state that has full practice authority, the premiums are the same because they don't see any difference in those outcomes. So it actually doesn't affect, and they're the experts on that, of course. So they would know because they set their policy for that.
Sure, I understand that. I'd also like to address the question, and it keeps coming up, and it comes up anecdotally, the idea that there's an average of $20,000 per prescribing authority agreement. When we worked with the nurse practitioners and the PAs in 2013, we certainly didn't envision anything of that nature. In fact, we found the idea of a 2-page agreement was a really good tool for both nurse practitioners and physicians to clearly understand precisely what was being delegated. Because in 2013, if a physician who did not even write for controlled substances wanted to delegate, there was no way of saying, well, the people that work for me shouldn't be writing for controlled substances either. Or that, I'm really not comfortable with this new physician assistant who just graduated from the program. So I'm going to limit their authority and we'll monitor it and see how this moves on. But the idea that folks are charged $20,000 on average is, I've heard it and we've asked for data on, and I've never seen any numbers. And I know, and I can tell, most nurse practitioners, most physicians, assistants are employed by physicians, medical groups, or hospitals, and so there would be no need to charge. There are nurse practitioners like yourself with an independent practice that have a contractual relationship. But I will say that we find even, that some of these numbers to be alarming. And frankly, I believe that the Texas Medical Board would be interested in looking at this because it would smell of renting or selling your license for a profit. And I think they would be most interested in a complaint, and if that's the case. But I know that so far there have not been any filings. But we continue to hear the stories about how many of these arrangements are out there. I don't think, I think the stories are very powerful and they're very attention-getting, but we haven't seen any data to indicate, that it's really.
There are two comments that I would make in response to that. Number one, I have seen the survey data from the Texas Nurses Association internal survey, and that 20,000 is the average number from a fairly large, but I certainly don't know the exact percentage of nurses represented. And it's also quite interesting that the range of cost for these prescriptive authority agreements was as low as $100 a month to as high as $10,000 a month. So the market doesn't seem to have much impact on those numbers. My second comment is I'd like to ask Holly, do you have one of these? And if so, what is the cost, or would you rather not say that?
Well, yes, obviously I have one because that's part of the Texas regulations. So yeah, I have one as well. And of course, those are contractual agreements between the providers, and those are private, not to be disclosed.
Okay.
Financial amounts, at least, not to break the contract. But I will say that it differs for people in our area as well. It depends on, okay, so I always say, I'm in rural healthcare, we don't have deep pockets, we have deep hearts, right? If if I would charge $10,000 a month, we would shut down. So I can't do that, you know, and so, but I still have a price that I have to pay for that.
Right.
Which, if I didn't have to pay that price, you know, this is really interesting. So, if I didn't have to pay that price, I have a community that I go to only one day a week because that's really all we can afford to go out there, and we need to go more. And our days are 8 to 8 already there. If I had that, I mean, I could send another provider out there 2 days a week and offer more care. Or I could go to another county again with no care there and hit that county. So it is a burden, absolutely, for us.
Okay, can we move on to sort of the bottom line question, which is there anything that the panelists would suggest that we do at the legislative level? So I'm obviously going to throw this at Representative Click first. What can I'll rephrase it, what can the legislature do to help ameliorate this shortage of primary care? And I would point out, before you answer, that as Holly said, it's in two forms. One is the rural areas where there just aren't people around. And number two, there are the inner cities where, now to throw it to Ann, where the number of physicians who accept Medicaid reimbursement schedules is so low that even though low-income patients have insurance, they don't have a primary care provider. So everyone keep in mind that those are two populations that suffer from a low amount, or an inadequate amount, frankly, of timely access to primary care. Representative Click, you want to tell us what you think you should do?
I think that we need to remove barriers so that all of our healthcare professionals are practicing at the full level of their education and training. That will improve access to care not only in rural Texas, but also medically underserved communities. And that could be in a large urban county where you have pockets of medically underserved communities. Areas that have a high percentage of senior citizens, they're typically in that medically underserved population. We need to remove these barriers, and we need to do it soon. We are at a competitive disadvantage. Other states are recruiting our professionals away from us, and that is adding to the shortage. And I think APRNs are well suited to help stand in the gap, because the amount of training, the time involved, is shorter. We can produce far more advanced practice providers in a 4-year period than we can physicians, because their training is much more involved. And we need to do it soon.
Ann, your thoughts?
Yeah, in fact, we were.
You're not
Sorry.
Ann.
Oh, I'm sorry. I said Dan.
Did you say Dan or Ann?
I said Ann, and I apologize for my lack of enunciation.
This will be short anyway.
I'm a pre-senior citizen, so my
Yeah.
brain is going.
Me too. Anyway, I was going to say that one of your comments earlier was about your questioning the theory that there'll be improved access in underserved areas. And I just want to say again, I just have to look at the research, and all the research shows a higher incidence of accepting Medicaid by advanced practice nurses, higher likelihood that they work with medically underserved populations and in medically underserved areas. So, I don't think the fact that Texas' current location is what it is means that changing the rules of the game will have no effect on future locational decisions. I would also point out that, as you know, and as has been mentioned, we are, I think, vying with Tennessee for the highest rates of rural hospital closures. Maybe we have the biggest numbers because we obviously have a lot more real estate than they do. But you know, it is not the single thing that rural Texas needs for healthcare. And one of the things that contributes quite a bit to it is the fact that there are so many uninsured people for whom there's no source of payment. So everybody who's providing care has either got to say no to those people or figure out a way to pay for them. I just would mention that there was a poll that came out in June of Texans, a pretty detailed one, and in it, it said only 30% of Texans even knew that Texas had above average uninsured rate. The majority of Texans thought that we either had average uninsured or were better than the national average. So if nobody remembers anything else about what I said today, we actually have the worst uninsured rate and the biggest uninsured number. My mic went out right when I was saying that. And the biggest uninsured, it's a conspiracy. So I mean, I think,
I promise
you know,
it isn't.
I don't think we want to oversell that every problem of rural Texas is solved by this, or every problem of inner city Texas. But this is a big piece of the puzzle.
I would like to take up on that for 1 second, and that is the data really nationally is very clear that when patients have timely access to APRN care, obviously it'd be nice to have a primary care physician in Raymondville Falls, population 9,800. Nonetheless, that's not likely to happen. When you have timely access to an APRN, there is a segue here. The number of ER visits and hospitalizations goes down considerably, which then turns around and reduces the cost basis for that rural hospital, which is struggling just to survive. So an indirect advantage would be a reduction of their cost basis by timely APRN primary care. Dan, you had some thoughts?
Yeah, and this goes back to a conversation we were having earlier.
Closer.
And this goes back to a conversation Representative Click and I were having earlier about Medicaid. There's a couple of reasons why Medicaid participation rates among all health professionals is so low. Primarily, there hasn't been a rate increase in the Medicaid payments for nearly a generation. It's 15 or 16 years. It increased only once modestly, actually twice. Once modestly as a result of a lawsuit settlement in 2007, and then temporarily as a result of the first 2 years of the Affordable Care Act. But generally, those payment rates have been flat. Number two, and it has to do not with the payment rates, but it has to do with the overwhelming administrative burden placed on the credentialing process. I've got
if I may, it's not just, you're right, but it's not just the credentialing, it's also the whole regulatory compliance. Speaking as somebody who has lived in Medicaid for 40 years, my average reimbursement rate for billed services was 11%. Okay, let's just think about that for a second. Having said that, the regulatory burden, you talk to anybody who has a large Medicaid population, it's a nightmare.
It's overwhelming.
Yes.
And I know, and maybe this is by design, but I have doctors that will provide services for no fee, simply because that is actually more cost effective.
It's true.
And it probably works to the advantage of the program in some way, but it is a bad way to organize care for a population that truly needs it, and it needs more of it than most.
One of the other issues, despite passing legislation last session, a lot of NPs that do take and see Medicaid patients, some of the providers or insurance companies are not paying them because their delegating physician is not in network. And that is a huge problem.
I thought we addressed that.
They believe that it's permissive, not required.
That's
And
the
we're going to
insurance
fix it.
That's
We're
the
going to
insurance
fix
claims,
it.
right?
They either fix it or I will.
We probably should have a plan representative here.
Well, I would comment that most of the administrative burden related to being a provider of care to a Medicaid patient these days is not in a relationship with the state, it's in a relationship with an HMO. So
Right.
nearly all of our 4 million Texas Medicaid enrollees are in a
Yes.
risk-based HMO today.
Yeah,
Sure, it
it's,
is a managed care environment.
it's important for the folks that are in the audience to understand that if a nurse practitioner is providing services to patients and they lose that delegation agreement. I met one recently that the physician that was her delegating physician died in a car accident.
Mm.
She's not able to take care of patients. And that leaves them in a lurch without access to care.
So I can say something to that because, so in one of our major clinics, we have the city itself is about 2,600 and the county has about 6,500, but we have over 12,000 patients. And that just tells you we pull in, we're real rural health. So if that happened to my delegating physician today, we have 12,000 patients with nothing to borrow.
We gotta fix that.
So that's one of the huge issues with the prescriptive authority agreement, and it's definitely, if you're a business person, it's not a good model to set it up as, for sure, but it's a problem.
There's another problem with the prescriptive authority agreement oversight that as a physician I have to bring out in the open, which is if you don't have concurrent, that is real-time supervision, if an APRN were to make a mistake, just like if I made a mistake, but if an APRN made a mistake and the review of her charts occurs 3 weeks later, the patient still has the adverse impact. In other words, the safety of the patient is not protected by a periodic review of the charts. The other thing I must say is I actually looked at, because we did research on APRNs, we here at TBPF, I looked at the actual curriculum that Holly, APRNs go through, and they do go through an extensive study of both differential diagnosis per se, as well as pharmacotherapeutics, which is not pharmacology, which is the study of drugs, but pharmacotherapeutics, which is the study of using the drugs on humans, well, on people. And so they do study this, and within the limits of what they have studied, all the evidence shows that they're very safe in independent practice. I don't know if Representative Click remembers, but I reviewed, one of the things we have to do when you're doing a patient or anything is review the medical literature. Well, I reviewed the medical literature, this is last session, so it's 2 years ago, on APRN safety and effectiveness, and I handed the chair of the Human Services Committee a blue 3-ring binder with 124 studies, each of which I had read and reviewed on showing the safety of APRN practice in primary care, including, rather interestingly, a very large study from the VA over something like 15 or 20 years. And so they felt very comfortable doing what Holly said, which is giving the APRNs full scope of practice. I think I'd like to, unless someone has something they'd like to end with, I'd like to open this up to our audience and have them ask anything they'd like. Any comments first, colleagues? Okay, then let's open it up. We have a floor mic, or you want to come up, Clark? Dan, can I steal your mic and just...
Shall I throw it?
Not recommended.
It's not a boomerang, it won't come back.
Yes, when it comes to the supply of RNs, APRNs, and doctors, I mean, why can't we just really just open it up completely to the free market? evidently one of the most competitive aspects probably the most competitive part of healthcare in the U.S. is getting into med school, and there's no other field that I'm aware of when it's like that. So, again, evidently the AMA has a very strong impact on reducing the seats in medical schools, and so, I mean, why couldn't we just open up the supply like every other field, major field in the U.S., just to the free market itself?
Anyone want to take that, Dan?
Yeah, it's an interesting proposition, but we've seen medical class expansion. Texas Tech several years ago expanded from Lubbock to Midland and El Paso. We've added the University of Texas Medical School at Rio Grande Valley in McAllen. And now we're talking about additional medical schools in San Houston State, University of Houston, and TCU. So the idea that we're artificially choking down on medical school seats is not there. I mean, we continue to build more medical schools and I will tell you that as we expand medical school enrollment, because we need doctors for the future of Texas, we also need to have a corresponding commitment to growing graduate medical education programs. And that's residency training, where doctors learn how to, where they specialize in family medicine or surgery or anesthesia or what have you. And that's usually another 3 years, 4 years post-medical school to train as a specialist. But it is as true today as it was a generation ago. And Dr. Dean, this may not be your experience, but 80% of doctors end up staying within 100 miles of where they train.
Where they
train. Now,
that's right. That's exactly right. It's not where you went to medical school. It's where you did your postgraduate training. That's I'm surprised it's only 80%.
And so, it's been consistent for a generation, so I kind of figure it'll hold up. And it is a bad investment on the part of the state of Texas to build and fund medical school education and then not provide those students an opportunity to train here, because then we end up training the next generation of physicians for Oklahoma or Michigan or what have you. And frankly, I've made the point before, and maybe to Representative Click, we ought to be closing down one of these schools or two. So, we take that money, put it into graduate medical education.
But
They said, that's a great idea. Which one should we close? And I said, Representative, that's your job. That ain't going to happen. But the idea is that as we expand medical school enrollment, and I know that the school in San Houston State is going to be primarily for primary care doctors. We have to grow the residency training programs along with them.
That is very true. I can tell you the statistics are really alarming about the limited number of residency positions. It's not really the medical school as much as it is residency positions, number one. Number two, you talked about free market. Now let's talk the reality of the average medical student in the United States graduates, this is national, I don't know Texas data, graduates with a loan amount of $184,000. Okay? Now, either you're going to skip out on that loan, which is a little hard because you need a license to practice medicine and they can always find you, or you're going to go into a specialty that pays you more. And that's why there's this very large economic push for, frankly, specialists. Now, sure, it's a little easier. I mean, let me just say this bluntly. It's much easier to do what I do or did, pediatric cardiology, than the entire array of what a primary care physician does, because when the kid comes to me, I already know it's his heart that's the problem. But when somebody comes to Holly with abdominal pain, she doesn't know what it is. Which organ is it? It's much harder to do what she does than what I did, but I got paid more.
If I could add that there is one other avenue for helping to pay off that debt, and it's a staggering amount. And that is, several sessions ago, really beefed up the rural loan repayment program. And so I think
Yes.
we now, over a period of 5 years,
Good idea.
allow a physician.
Explain it, please.
It is a fund that allows a physician it's an increasing amount every year. If they will locate to a medically underserved area, then by the end of 5 years, they will have been able to pay off $150,000 of their existing educational debt from this program. And it actually increases a little bit every year. In the very first year we did that, we had 132 physicians that took advantage of it and were placed in medically served areas around the state. And that happens every year. And to the degree that we can maintain funding for it, that is another avenue.
Yes.
I mean, it's a beautiful idea because it meets two needs. The opportunity to help somebody pay off a debt, it keeps them in primary care for the most part, because they don't feel like they have to go to a high-paying specialty in order to pay off $180,000 worth of debt. It keeps them there, and it actually puts them in rural areas for at least 5 years. And of course, what we find is that when folks are someplace for a period of time and have established a practice and have established relationships, have established a family in large part, they tend to stay there.
There is also a mental health professional loan repayment program that is similar because of the great need that we have for those professionals.
I think the one of the takeaways, and this is a question for the entire panel, is we need more. We need more healthcare professionals, and specifically in terms of like PAs, nurse practitioners, RNs, APRNs. If y'all would speak to what are our K through 12 public schools doing right now to be able to, because these are great jobs, to graduate young men and women who can step into post-high school, the medical profession, or if not that, they're just a step or two away without having to spend years going to college. What are we doing already to graduate students who are trained, certified, or ready to enter the medical field? And what more do we need to do to get more of those type of people who can immediately start that type of career with whatever kind of training, certification, or license that'll make them marketable from the get-go?
Great questions. Anybody want to take it on?
Yeah, first
Representative
off,
Click?
Yeah, you're talking post-high school education. It's not something that someone is going to graduate from high school and be able to go to work. It's going to require college training to get there.
Well, actually, he meant preparation in high school for then technical school, technical training, technical whatever you want to call it, after high school.
Yeah,
Is that valid?
Both potentially. You have high school students that do college prep courses already, and they said some of these degrees are maybe a 1 or 2 year certification, typically post high school. Can that be pushed down? We get more graduates who, maybe able to get those certifications at the same time they're getting their high school degree, or maybe just need a little bit extra education rather than starting fresh on the application.
Holly, you had some thoughts?
Yeah, in rural areas, you really grow your own, right? And so one of the things that we do, which I have a phenomenal example of this, we had a high school student that worked for us and just helped us at the front desk first, and then she worked her way to the back. And then she became a medical assistant, a certified medical assistant through a high school course that graduated with. And then she went on and continued working for us as that, and went on and became an RN. And she's now been an RN for 3 years, and she's in NP school. And so she's going to be a future member of our team. And that's how you keep people in rural areas. You grow your own. And it's just been phenomenal. So we've had that model, and she's not my only one. We have several. We really encourage education, and we work with the high school students. And so basically, in our rural areas, we allow those high school students to come to our clinic and they get that experience. And some of them, it's not for them, and that's okay. But a lot of them, it's their first introduction to healthcare. And that's what we have to do, is expose them to that and let them get that experience, and then encourage them, hey, you can do this too. And so, yeah, that's great.
Ann, any thoughts on that? I love what Holly has done. I wish we could replicate it for 253 other counties in Texas. Go ahead, Ann.
Okay, it was an and problem again. No, it happens a lot. I thought he called on you.
I always go to her first.
No, I don't have a lot to ask to what Holly said, but, obviously, focusing on, making sure that kids are getting good preparation for STEM, for, science, technology, engineering and math directions. And I think the observation she made that there may be some very entry-level kinds of training that only take 1 or 2 years, but almost everything we've talked about, whether it's getting your RN, getting your advanced practice, and then even longer to get an MD, those are longer trains. So that idea that you get people hooked, and then maybe that can help them make their way through getting a bachelor's degree, and then maybe getting additional training for some as they move up the ladder of complexity. But I think this is not the only area that's like that. I think, the whole idea of making sure that, we're enriching the K through 12 experience, and that it is intelligent about what the needs of the workforce really are, what giving kids skills that can really help them get jobs. I mean, those are huge things that everybody agrees on, but we still have a long way to go, perhaps.
I was just going to add that I think your question is right at the intersection of public responsibility and public need, and it makes it really even more important because it brings into our need to grow the workforce of the future with our need to educate kids today to be ready to be part of that future. And it's a wonderful question that has no answer.
Yeah, that's why we asked Representative Click to answer it. Other questions?
So my question is, what will it take for advanced practice RNs to have full practice authority? I mean, can it happen this session, or are we going to have to continue to wait many more years? Anybody can take that. But.
What it takes is 76 votes in the House, and the same number of a majority in the Senate to pass it, and we need it desperately.
I will say that there is a coalition of groups. I really, frankly, enjoy having Ann sit right next to me, because the coalition to release the APRNs is now up to, I think, 23 different entities in Texas across the political spectrum. Because whether it's Ann, who, if I may, is left, shall we say, or me, who we will call right.
We are both independent and nonpartisan.
That's right.
But,
no, that's right. No.
But those
Yes.
characterizations are not wrong. That's right.
The point is, I think most people would agree that we tend to be on opposite sides on certain issues politically. This is an issue we're not. We are unified in that this is a good move and are trying to encourage the legislature to move in this direction. I'm sorry, louder?
So my question is, do you think it will happen this year?
Well, then I'm going to bounce that right back to Representative Click.
I'll let her off the hook a little,
Okay.
just because I won't get in trouble. Nobody cares what I say.
She just got reelected. She's
Yeah.
safe.
Yeah, that's true. She's very safe. But I just want to say, I think that everyone's concern going into the 86th is to what extent we see a repeat from the 85th, which was there was so much rancor between the two chambers, not even partisan rancor, but just House versus Senate,
True.
that you felt like you could have the bill for motherhood and apple pie, and you still might not get, if it came out of the House, you still might not get a Senate hearing. So I think that's affecting many issues, and finding
Yes.
an issue that will not touch going into the 86 is a challenge for all of us. So everybody's always looking for across the aisle kinds of issues. People, we really do like to do that stuff, get things done and not just fight. But it is, that dynamic is very uncertain going into 86. As we know we will have a new speaker leadership on the House side, but we don't know who it will be. We just don't know what that dynamic will be. Fingers crossed that we can make some progress on it. We certainly had a good hearing.
We did. We had a very good hearing, and it's an issue that I've continued to work on during the interim. Have traveled the state visiting NP-led clinics and had some of my colleagues come with me to learn more about this and the valuable services that these NPs provide to their communities that have no other providers. And our coalition of organizations that are supporting this idea is growing. And I'm hopeful that we will move the ball forward next session. What that will look like, I don't know yet.
I know we'll have those conversations.
Right.
And I'm reminded that the only real statutory responsibility for the legislature at any given session is to pass a budget. And every year we say maybe that's the only thing they actually will do, and who knows. But I will say this, and it's been consistent over a decade at least. There are 7,000 or more bills or resolutions that are filed in every 140-day session, and 30% of those bills deal in some way, shape, or form with health care, either big or small. Health care is huge business in the Texas legislature. It keeps us busy through the interim, which begins to look less and less like an interim and more like a session because of all the activity. And you know that as well as anybody because of the demands that are placed on the members' times as well. So I have no doubt that this conversation will continue until May the 29th. Is that right? And
Other
well
questions?
beyond, I'm sure.
Anything else we can solve for you? We'll get you a mic, and then you're on.
Well, I got a maybe that's a little too close there. Have a question and a comment. Comment is on the medical schools. I remember when I went to college 30 years ago. This is when the legislature had tuition rates regulated. I paid $200 to go for 15 hours at the University of Texas. And if you're as old as I am, you remember those days.
Yes.
I guess, I remember those.
It's a heck of a deal.
The big problem you had back then on the medical schools, because I knew fellow students who wanted to go to medical school, even back then, 30 years ago, obviously the gentleman over here brought it up, the qualifications, but the other big issue was the costs, the tuition costs. They were far, far higher than it was just to go to a four-year school, or even graduate school at that time. So when I believe it was Craddock in the early 2000s that lifted the tuition rates, guess what your universities did? Hiked them, big time. That's a big issue, for anybody going to college today is what it costs on the tuition, even outside of medical school. But I guess the question I've got, and this is a political one, strictly, although it relates not just to medicine, but to a lot of areas, would we be better off with a one-chamber legislature? In other words, would legislation be, and I know there's not an answer to this, I don't think, would legislation in general, you mentioned about all the votes in the House, all the votes in the Senate, then you got to come to a conference committee, right? Iron them out, and then it's got to go to the governor. Of course, the governor has a final say, but would we be better off with one chamber? Would it be more effective in passing legislation? And Congress, eventually.
I can only think of one state that might have had a unicameral system.
Nebraska.
And I've heard it works pretty good up there.
And it may, but I also think that there's some advantage to the, even though at times it gets difficult when there's cross-chamber rivalry, if you will, there is still something to be said for the process with having two different chambers. In the House, there are much more of us, 150 members. We don't have the staff that a lot of the senators do, much smaller staff. And in the Senate, they rely more heavily on their staff because they're frequently on 7 committees. You know, in the House, you're generally on 2 or 3. And on that 2 or 3, you can really dig down deeper than perhaps you might on the Senate side. So there's advantages.
And
to
I don't
both.
think we should forget that the founding fathers, and you're going to say this is Congress, but the principle applies everywhere. The founding fathers intended,
To be
with the
hard.
structure that they created, to make it hard for politicians to do things to the people. I say no more.
One of the things that's appealed to me about some other states' legislative structure is that in some legislatures, there is a strict and very low limit on the number of bills the legislators can file, so that there's not the blizzard that Dan
I didn't know that because,
mentioned, yeah.
I mean, anybody who's looked at the bills, you can find the same bill effectively in 4 different forms, 5 different forms, and with just a couple of words different. And that's an interesting thought.
I'm sure it just results in a whole lot of giant omnibus bills to a certain extent, but you know, I think this is a fascinating discussion. I mean, I often feel like, and I'm not at all a student of this, but that, you know, the parliamentary structure that forces multiple parties to find consensus and cut deals. You know, I think everyone right now is exceptionally frustrated with the level of non-productivity in our Congress. So, you know, if there was something we could do to increase the need to collaborate, then it would be a great thing. But that's not low-hanging fruit for sure.
Probably could increase the efficiency of Congress by limiting them to 140 days every other year.
How about a term limit?
Those are called elections, aren't they?
Yeah, vote.
We could have a lovely discussion about that.
That's another lunch.
That's a weekend retreat. And yes, sir.
I actually just had a quick comment about the 140-day Congress, and I just want to mention that in
Legislature.
2012, when he ran for president, Rick Perry actually proposed that
Proposed it for,
for the U.S. Congress.
Thank you.
Maybe not 140 days, but Rick Perry definitely proposed a part-time Congress.
And we should pay them $600 a month.
well, excuse me, again, back to the founding fathers. I mean, you were supposed to serve for a while and then go back to your real job. Okay? Yeah. I don't know, I still say the principles are pretty good. Last minute questions, final question? Well, then I guess we are going to have a hard stop. I do appreciate everyone coming. Please thank our panel. They have done a yeoman job. And thank you.